Ryan Vandry, PhD. Dr. Vandry is Associate Professor of Psychiatry and Behavioral Sciences at Johns Hopkins. His research focuses on the behavioral pharmacology of cannabis, among other things. Welcome to Cannabis Economy. I'm your host, Seth Adler. Check us out on Twitter, Facebook, and our new YouTube channel with the handle Can Economy. That's two N's in the word economy. Or visit the website cecono.me for the over 125 episode catalog, including the Charlotte's Web episode 121 with Charlotte's mother, Paige Figge, and Realm of Caring's Heather Jackson. Heather is who introduced us to Dr. Vandry, and he lets us know what he's doing with them on researching the plant, Dr. Ryan Vandry. We have PhD Ryan Vandry from Johns Hopkins Bayview Medical Center, who does research with cannabis. How accurate is that, Ryan?
That's pretty accurate. Technically, I'm in the Department of Psychiatry and Behavioral Sciences at the School of Medicine.
Aha. Okay, so I think a website needs to be updated, but you are absolutely somebody that we want to talk to. You're doing research now, and we appreciate it, and we'll get into the fact that you also have done research with cannabis. So let's first talk about what you are doing right now as far as research in cannabis.
Okay, so I have multiple projects going on like any good scientist would. One of my main things that I'm looking at in the laboratory right now, and let me actually go backwards. So I do a combination of controlled laboratory experiments, clinical trials, and getting into more exploratory survey research. Mm-hmm. So in the laboratory, which is where I spend most of my time, I've been working on a series of experiments that are trying to characterize the pharmacokinetics and pharmacodynamic effects of cannabis when administered through different routes of administration. So, for example, we've done a handful of studies that involve smoked cannabis administration over the years. The last 2 years, we run 2 studies where we looked at dose effects of edibles. And we're about to launch another study where we're going to be comparing directly vaporization to smoked cannabis administration.
Okay. So let's kind of make sure that we all understand what you're talking about. So as far as the pharmacomechanics, did I hear you say that correct? Or did
Pharmacokinetics and pharmacodynamics.
Okay.
So those are fancy words for 2 things. Pharmacokinetics is what happens to the drug when you ingest it. Okay, and so basically what we look at there is evaluating how long the drug stays in your body, at what levels it stays in, how it's metabolized, and you look at that over time. Okay. And then the pharmacodynamic piece is the effects. So what do you feel subjectively? Does it affect your performance in terms of cognitive abilities in any way? Those types of things.
Okay.
So
go ahead.
What it gives you is it gives you a snapshot of what the entire experience of receiving the drug is, and then you can look to correlate levels of the drug or its metabolites in blood or in urine or in spit with the corresponding subjective effects and performance effects and cardiovascular effects that happen.
Okay, so you can really get a definite understanding of exactly what's happening.
Yeah, and the reason that that's important is because most of the research that's been done has been focused on smoking as a route of administration. Mm-hmm. Now, with the onset of, legal access and an actual commercial retail marketplace for cannabis, in half of the U.S., you're seeing capitalism at its best, where people are trying to find new and novel ways and novel products and in exploring different routes of administration.
Sure.
And, that's all fine and good, but it causes issues when you're trying to understand the science of what's happening and how to make recommendations about dosing and how to understand in, say, forensic cases, for example, how to interpret, the behavior that you're observing with the blood levels of a drug that you're measuring.
Okay.
So one of the really interesting outcomes that we found with the edible research is that
I want to stop you. I want to stop you before
Okay,
edibles.
sorry.
No, that's fine. We kind of want to make sure that we cover everything. And so,
Sure.
you did mention most of the research that has been done has been done on smoked cannabis. So let's now take the opportunity to talk about when you first started to do research on smoked cannabis.
Sure.
When was that?
Yeah, well, so my initial research started in graduate school at the University of Vermont.
What year was
That was in 2000.
Okay.
And my mentor up there, Alan Budney, was just getting started with 2 lines of research. One was developing treatments for people trying to quit using cannabis, and the other was evaluating and trying to characterize cannabis withdrawal. At that time, most people did not believe that cannabis withdrawal exists. To this day, there are still some holdouts, but we were able to conduct a series of pretty elegant studies that showed very clearly that if you're a heavy cannabis user and you stop abruptly, a constellation of withdrawal symptoms emerges, and it looks a lot like tobacco withdrawal.
That was going to be my question.
Yeah, so it's not the the vomiting and shaking that you see with opiate or alcohol withdrawal. It's not life-threatening in any way, but it is there, and it causes individuals discomfort. And so we were able to kind of demonstrate that cannabis withdrawal is real. Here's what it looks like, and it is a barrier to people who want to quit from being able to do so in some cases.
Okay. As far as if we are going to take the tobacco example, as far as pharmacokinetics, as far as pharmacodynamics, what are the similarities between cannabis? And go back to that study, please, in 15, 16 years ago. What are the similarities and differences between tobacco and cannabis? If we understand that there are similarities in terms of quitting and withdrawal, what about actual use?
Yeah, well, I mean, they're both smoked predominantly, and we have, kind of comparable markets emerging with the use of vaporization with e-cigarettes and vape pens and things like that.
Right, which we'll get to.
Pharmacologically, the drugs are very different, although there is some interaction between the endogenous systems that receive and modulate the effects of those 2 drugs. So nicotine acts through the acetylcholine nicotinic receptor system, and the primary psychoactive or biologically active components of cannabis modulate the endocannabinoid system.
Right.
Those 2 have some crosstalk, but by and large, the effects of the drugs are pretty different.
Okay.
The time course of effects are very different. So cannabis effects usually last a bit longer than nicotine. But when you look at the withdrawal symptoms, they're similar both in type and magnitude. But that extends beyond just those 2 substances. So most of the symptoms of withdrawal.
Before we go to other substances, you mentioned a couple times that the effects are extremely different. You mentioned psychoactivity as far as cannabis is concerned. How, in what other ways? And what I am trying to do, I guess in a heavy-handed way, is to ask you to tell us good things about cannabis and bad things about tobacco.
Well, I'm not going to do that because I don't have that type of agenda.
Indeed.
Yeah, so uh, that's not my mission. My
Right.
mission is to study the science and present facts in a fairly objective way.
Indeed.
And when you look at both substances, there are positives and negatives with both, and
Indeed.
it'd be silly to focus only on one versus the other.
Right. But as far as those effects are concerned, and now that we've kind of let the cat out of the bag, we understand your point of view, we understand my point of view. Can you give us just a little bit more detail on the difference of the effects of cannabis and tobacco?
Well, sure. I mean, so each one is plant derived, and there's a primary psychoactive component of each that kind of drives behavior. For cannabis, it's THC. Now, the cannabinoid system is, widely spread throughout the body, and as a result, cannabis has a number of different effects. It helps modulate appetite and memory and mood and reinforcement and pain and all kinds of stuff that I'm sure you and your listeners are well versed in.
Indeed.
And nicotine is the primary driving component of the behavior of tobacco use. So it's a reinforcing drug, same as THC. So the commonality there is that both of them stimulate the release of dopamine in our brain's pleasure center. And that's common, again, across all drugs of abuse. And it's that commonality that I think drives the similarity in withdrawal symptoms that you see across the two substances. So what you tend to see is when people use a rewarding drug, doesn't really matter what it is, you get benefit and you get pleasure from it. And when you use that repeatedly, your body adjusts to having that substance on board. When you look at patterns of heavy tobacco use and patterns of heavy cannabis use, again, these are folks that smoke either substance daily, usually multiple times a day.
Right.
And so your body adjusts to that behavior, and when you stop that abruptly, your body tries to revert back to, it's not at its normal functioning level. And so you've altered the biochemistry of your body, and the end result is, well, you get agitated, you get restless, you have a hard time sleeping. Your body has to change back and adjust to the drug not being there.
Right. So if not dealing with a medical issue, such as Crohn's or epilepsy or, kind of counterbalancing chemo treatments. If we're talking about adult use cannabis, the recommendation here is moderation.
Sure, absolutely.
Right.
And I think that you bring up a very good and valid point. An individual's purpose or motivation for use is important in the development of addiction. And that is absolutely true for cannabis as it is true for other drugs of abuse. When you're using for medical necessity, it's different than using to cope with a rough life.
Okay, good. And because you use that phrase, drugs of abuse, a couple times, in your mind, is there a separation? It sounds like there is between medical use and adult use. It's an interesting word, abuse. Why do you choose that word, I guess?
Well, because that's typically what you end up seeing is the pattern of use becomes maladaptive for the person. That's kind of how we define abuse or misuse or addiction. And that really is the driving or the operating definition that has to come with that type of connotation and that label. So you could have two individuals that use a particular substance, and we'll use cannabis in this example, at exactly the same pattern and frequency and amount. But one person is using it to mitigate excruciating pain, and one person is using it to get high and to to escape reality and not deal with their problems.
You and I would
And
disagree on that point, but we will kind of leave it and move on to
yeah,
to a next point. Yeah,
but the thing is
yeah,
is if you're using it as an avoidance, as a coping mechanism to
coping,
avoid
right.
reality,
Well,
and to avoid responsibilities,
yeah,
and it's causing problems in your life rather than helping you,
yeah.
then that becomes an issue. That becomes a problem. And
And
that's how
again,
we define misuse of a drug.
yeah, sure. Totally understood. I think that for the rest of the interview, you and I should avoid adult use and really just get to the science at hand because we have different opinions on. Well, we would use different words. I think is avoiding reality is not a phrase that I would ever use in terms of cannabis. It is one that you are using. That is fair. That is your right. Let's make sure that we understand who we're talking to. We just got through kind of smoked cannabis in your initial study in withdrawal. You are a PhD. When you were up in Vermont, are you from Vermont? Is that where you're originally from?
No, I'm an army brat.
Aha.
I'm from where I am. Right now I'm from Baltimore.
Right. That's what all the Army brats say. So right now you're from Baltimore. I guess, what states and countries did you experience, in your formative years?
I spent a lot of time in Germany.
Uh-huh.
I was born in Texas, but I don't claim to be a Texan because I was only there for 8 weeks.
Uh-huh.
Spent time in Philadelphia, North Carolina, Kansas, Delaware, Vermont, and Maryland.
Right. Amazing. What service was either your dad or mom in?
Army.
Okay. And was that your dad or mom?
That was my father
All
for
right.
23 years.
Wow. And thank you to him for his service.
I will pass along that regard.
All right. So he's still around.
Oh, yeah.
All right. And what did you kind of take from him? It's a very interesting upbringing. We've spoken to a number of folks who grew up the way that you did. I certainly didn't. What was the kind of the theme or the message or the key lesson that you took from your dad growing up?
Well, just being proactive, taking responsibility for what you're doing and your actions, and being a leader when you need to be a leader, I think is what I got out of that.
Right. Kind of try to be as open-minded as possible, and if you have to grab the bull by the horns, go ahead and do so, please.
Absolutely. And growing up in that environment, you're also forced to learn very quickly to adapt.
Yeah.
Which I think is important too. Because every 2 to 3 years we were changing schools and leaving friends and finding new ones and learning a new culture and all of that kind of stuff. And so that's played a really, really, really important role in defining who I am as a person now.
Once you did learn to adapt, what were some of the kind of key tricks that you used in a new environment on the way in?
Oh, I don't even know how to answer that one, to be perfectly honest. I mean, you gotta listen, you gotta be social, you gotta talk to people, and not be scared.
Right.
And you gotta try new things.
So when did you decide that this was kind of something that you thought you were going to do? Where did you go undergrad? Was that in Vermont as well, or no?
No, undergrad was at the University of Delaware.
Okay.
And I didn't have a very strong sense of what I wanted to do there. I started out as a biology major but didn't like it at all, and ended up going into psychology because I had friends that said it was really fun.
Right.
So at the end of undergrad, I had a degree in psychology and decided that I wanted to try to find a job that utilized that degree. I didn't really know what, but my favorite class was a psychopharmacology class. It was a class about drugs in the brain. And I was lucky enough to get a job here at Johns Hopkins at the Behavioral Pharmacology Research Unit as a research assistant.
And when was that? How far back?
That was 1998.
Oh boy. Okay, so right out of school.
Yeah, right out of school, and I worked here for 2.5 years. And, I helped conduct the types of experiments that I now design.
Hmm.
My experience here was amazing. I worked on studies that involved evaluation of cocaine and heroin and alcohol and tobacco and benzodiazepine sedative drugs, and again, of doing the types of laboratory experiments that I do now.
Yeah.
Everything but cannabis. And I loved the work, and I asked the professors that I worked for here, what do I need to do what you do for a living?
Yeah.
And so they said, you got to go to grad school, and here's a list. And so Vermont was, in terms of locations of other schools, far and above the most attractive place to be.
Sure.
So I was lucky enough again to find a position up there, and the person who had an opening for a graduate student was Alan, and he was studying cannabis. And so I kind of started with that and never turned back.
Alan Budney, a fantastic name to study cannabis. It's got Bud right in the name there.
Yeah.
I just have two questions, though, on what we just discussed. First, as far as your interest, it doesn't sound like you were a drug enthusiast. Why do you think that it was interesting to you?
It's fascinating. I mean, it's prevalent, it's everywhere, it's really interesting work. And when you look at drugs, and they do so many different things. You have, and there's so much to learn and know about. And so that's one of my why I've stuck with cannabis is that, I mean, there's been such a lag with controlled research with cannabis that there's literally a million questions to answer.
Right.
I've got 10 lifetimes worth of studies to do.
Yeah, that brings me to
and I'm
that
excited
second,
about it.
Yeah, that brings me to that second question, which is the fact that you did not study cannabis. Get into why. Initially, undergrad.
Initially,
Yeah.
I didn't have any decision on what I did. I
Got it.
worked on projects that people had. So what the work that I did and the studies that I was involved with were dictated to me, but they were incredibly valuable. The scientists that I worked with here are some of the founding scientists of the entire field of behavioral pharmacology, and so I have a really unique training background and was able to put the scientific method that we used in studying cocaine and opioids and alcohol and put that to task with understanding cannabis.
What are the similarities and differences? We did tobacco. What about alcohol? Compare and contrast.
They're completely different animals. I mean, again, with the exception that they are rewarding substances. People like to take them.
Right.
So
They have desire in common.
That's the commonality.
Yeah.
People like to take them. They find it rewarding, and it alters your state of mind. Beyond that, there's not a ton of overlap there.
Totally understood. What are some of the differences that you find interesting?
I mean, that's the differences are. I mean, there's so many.
Right.
I mean, completely different behavioral profile, completely different way of measuring the effects and measuring drug levels. So alcohol is really unique in that you have the drug in your breath. And so, you have your roadside breathalyzer as a test to determine whether a person is acutely intoxicated or not. You don't have that for any other drug.
Right.
And so it's interesting because a lot of the not to try to get you sidetracked again, but a lot of the research that, I'm doing in the laboratory, people are very interested in because they're trying to really hard to find some way of measuring whether or not somebody's intoxicated on cannabis on the roadside. But it's interesting because on the one hand, I think that would be valuable information to have, but you don't hear people clamoring for a breathalyzer for other drugs. that
Yeah.
could impair people's driving.
Indeed.
So we have it for alcohol, and it's very interesting and useful that you have it, but you don't really have it for anything else. But there's an immense amount of effort and an immense amount of interest in developing something comparable for cannabis. But probably because it's driven by the fact that so many people use cannabis versus other substances in terms of a reckless driving type scenario. But I think it's a little bit interesting that there's such interest and such a pressure to come up with something to detect cannabis on the roadside, but not for benzodiazepines or opiates or hallucinogens for that matter.
Right. You did mention, as far as measurement, blood, urine. You said spit. I wonder why, just as a sidetrack, why you use the word spit and not saliva?
Because I'm not a very formal kind of person in
Fair
most
enough.
cases.
But those are the three ways we could measure cannabis. Is that right or no?
Yeah. And I think the proper term is oral fluid. That's the preferred term among the toxicology community.
Interesting. That's also the name of the band I played in college. So as far as those studies, where are you? How are you involved in that in any way? I would imagine not. Correct. As far as measurement for roadside, but what about measurement for what you're doing? What have you found to be most beneficial, most telling? Blood, urine.
Well, I think that for I don't know about beneficial or telling. I mean, the research that I do does have implications for the roadside stuff. But what's fascinating to me is that basically the results from our edible studies call into major question current roadside testing practices.
How do you mean?
And so the roadside cannabinoid or THC levels that they look for in blood, again, are all based on research that was done when cannabis was smoked. It turns out that when you eat it, you have very, very, very low blood levels throughout the experience, even if you're incredibly high.
Right.
And so in the two studies that I've conducted on this, we've yet to have a blood sample come back that would have exceeded the roadside, commonly used roadside limit of 5 nanograms per ml in blood at any time point.
So let's now jump into this edibles research. It affects the body in a completely different way. You mentioned that. There is now, you're mentioning proof in that the blood tests simply do not tell the story of what's happening. How are you then finding the story of what's happening through edibles?
Yeah, well, so I would not say that it affects the body in a completely different way.
Okay.
I would say that it affects the body the same way. And you get the exact same types of effects that you get when you eat it, when you smoke it. The difference is that they last longer, and that the biological levels that you see when you're measuring blood or saliva or urine are different, and they don't follow the same time course as the subjective effects or the performance effects.
How do you mean?
So what you end up having,
yeah.
So what you end up having is when you eat a drug, and this is not unique to cannabis, when you eat a drug, you have a much slower onset of drug effects and they last longer. And that's because the drug is slowly absorbed into your bloodstream from your gut. And that results in a much slower availability of the drug to your brain, but also a prolonged availability in your body. And so that's one of the reasons that I think edibles are becoming popular, because when you're looking at therapeutic uses for cannabis, there are certain chronic health conditions where you want longer lasting effects, more stable drug levels, and things of that nature, where eating the drug is going to be more beneficial. But, then you go back and you look at other things where if you have like acute onset pain, waiting 45 minutes or an hour for your drug to kick in is probably not the best route of administration.
Indeed.
And one of the other things too is that, when you look out at the experience in the legal markets, you have issues with people using too much, using not enough, and really there's an initial struggle and lack of basis for establishing what an appropriate unit dose is for an edible. Colorado was the first state to come out and say for their non-medical program, 10 milligrams is an appropriate unit dose. And I talked to the folks at the Colorado Department of Health out there and said, how did you come up with that?
Right.
And they just laughed and said, you don't want to know.
Oh.
And I was able to tell them the results of my study and say, well, guess what? I think you got it right. And they said, whew. So, when we did the studies in my laboratory, I picked 10 milligrams as the lower threshold dose based on the decision that was made in Colorado.
Okay.
Partially, and then the other part was based on the research that we had done previously with dronabinol, which is an oral synthetic THC medication that's on the market. And then we went up from there to 25 milligrams and 50 milligrams. And what we found was that in non-cannabis users, 10 milligrams will give people an effect. It increases their heart rate. They feel a little high, but it didn't impair performance relative to placebo, and there were very few negative or uncomfortable effects of the drug. But as soon as we bumped up to 25 milligrams and even more so at 50 milligrams, then this group of non-tolerant individuals started having some of them started having uncomfortable side effects.
Okay.
We had nausea, we had vomiting, we had people getting dizzy every time they stood up. We had a couple anxiety or paranoid panic reactions. So at 10 milligrams, that really wasn't evident.
And that is why we have the phrase start low and go slow as far as edible use for non-tolerant individuals, as you say.
Yeah. The tricky part too, and this is one of those areas where I think Colorado is leading the way, is in education about that.
Yeah.
Because you hear too often that people will eat it, expect to have an immediate drug effect, and they don't, so they eat more, and then they eat more, and then they're in trouble.
Yeah, then they're
and
up
I think
towards
part
50.
of that is perpetuated by, I have a big problem as a pharmacologist with how drug use is portrayed in the movies and on TV.
Sure.
It doesn't matter how you administer a drug, it like kicks in immediately. And so when that doesn't happen to people in real life, they think they need to take more.
Sure. That's it.
It's just a bad idea.
Indeed. So I just want to get back to measurement. We talked about, as far as edibles, blood not being a great way to do it. As far as urine or oral fluids, as we've come to realize, is there a better pathway as far as measurement in terms of, from your perspective?
Well, we can measure THC and its metabolites in pretty much all of those, but the amount that we measure, or the window in which we measure it, none of it lines up with the actual behavior. And so that's one of the challenges. That's the trick right now, is that when you measure in blood, blood correlates pretty well with drug effects if it's smoked. If you are eating it, that's not the case at all.
Right.
If you're looking at saliva or oral fluid, basically if you're eating it, what you're measuring is contamination. You're measuring the plant material or the oil that you just chewed up in your mouth, and that the effect is, or the detectable THC in saliva is gone within 2 hours, but the drug effect lasts 6 to 8.
Right.
And so basically, if you were to try to overlap the measurement of the drug or metabolites in either blood, oral fluid, or urine, and then you line that up with the time course of when you see people having a high or other type of drug effect that you're measuring, there's just no overlap or very little overlap.
That's
So
fascinating.
so essentially right now there's no good biomarker of acute drug effects for cannabis.
It does sound like, though, in terms of edibles, those first 2 hours, I guess maybe towards the back half of those first 2 hours, saliva, spit, oral fluid, whatever, would be somewhat accurate, more accurate than blood. Is that fair?
No, because blood levels are going, or the oral fluid levels are going down as the intensity of the drug effect is going
Uh
up.
huh.
And then by the time the peak drug effect onsets, you're not seeing any THC in spit.
And then, obviously, following on to urine, you're not seeing it there either.
Yeah, urine, you don't see any. So in urine, you measure a metabolite of THC called carboxy THC, and you typically don't start to see that in urine until a couple hours after it's been ingested, whether that's smoked or eaten.
Okay.
So you miss the front end on that. But then in urine, a single administration can be detectable in urine for, we've seen it as long as 9 days.
Okay. And if we're
So
then
that doesn't work either.
right, because then it becomes only 6 to 8 hours versus 9 days.
Yeah.
Yeah. Okay. So then, I guess you're the smart guy. What other methods are you using for measurement? What else are you looking at aside from what we've already discussed?
Yeah, so I've kind of exhausted my area of expertise in terms of the toxicology, but I'm collaborating with people who are trying to evaluate other methods of finding biomarkers, and they're starting to get pretty exploratory and pretty sophisticated. One person that I've just started talking to is interested in kind of replicating some of these studies and looking for biomarkers of changes in DNA expression or something like that. Another person is literally an analytical chemist who's going to go in and just look at everything possible that they can measure in blood and in oral fluid and try to find anything that follows the same pattern or time course as the drug effects that we see.
Yeah.
I mean, right now I don't know that there's anything that's really promising, but people are still looking.
Okay, so that's toxicology. As far as the way that we were introduced, it was through Heather over at Realm of Caring.
Yep.
What are you working on with them? How much can you tell us, and what are you finding?
Well, I can tell you what we're trying to do. I can't tell you what we're finding because we haven't gotten to that point yet.
Right. When by the way, when is that that you do expect to have findings?
So let me explain what we're doing, and I think that'll answer that question.
Thank you. Yes.
So the Realm of Caring is a really neat organization, and Heather Jackson is a fantastic person who I've really had a pleasure working with. So they have a foundation based in Colorado with a little over 5,000 medical cannabis users who are registered with the foundation. Now, most of the patients there have a seizure disorder, and a lot of them are children.
Right.
And to give Heather really the benefit of what she's been doing here, they recognized the need for data and for understanding and knowing and putting research behind their mission. And so what I'm doing is I'm helping design questionnaires that we are going to ask their patients to complete every 3 months. And so what we're going to do, the value that we're going to get there, is we're going to have people in real time giving us information about who they are, what their health problems are, what type of cannabis or cannabinoid products they're using, the dosing, the frequency, and all of that kind of stuff. And then they're going to give us health outcomes on a point by point basis over time.
Great.
And so we're going to be able to track use of products by health conditions and subsequent health outcomes,
Right.
and look at how those change over time. And that to me is something that should have been done for the last 20 years,
Or 80.
going back to 1996 when California first passed medical cannabis law and allowed patients to use cannabis. I mean, I think that as a field of people involved with medical research, we've really missed an opportunity to collect information on the outcomes of the people using cannabis.
Absolutely.
So my mission is to change that and to take advantage of the opportunity that we now have. And we're lucky to have a partner with the Realm of Caring that's going to provide us access to a large sample of patients who, to this point, seem very willing and eager to provide the information that we need.
Yeah. So as far as the information, you did go through kind of what will be on that, or what is on that questionnaire. As you mentioned, 3-month segments. Why that time frame?
I think any more frequently than that is going to be too big of a burden on the patient.
Okay.
And I think 3-month segments will give us a nice look at changes in trajectory over time.
Okay.
So it may be that once we get going, we modify that time frame a little bit. But initially, for me, we don't want to turn people off to this or make it aversive. But we do want to make sure that we're collecting information frequently enough to track these kinds of changes and not lose people.
And as far as findings, now we're here. When do you expect to be able to show the world a little bit about what you're learning?
Yeah, so Heather and the Realm of Caring group collected an initial set of data from epilepsy patients a year ago.
Okay.
And my colleague, Dr. Marcel Bondmiller, has been looking at and analyzing that data over the past couple months. I think that we're pretty close to having outcomes from that, so we'll be working on writing up a paper and publishing the results of that initial study sometime in the next couple months. We've just finalized a new survey that's going to be launched. My hope is sometime within the next 2 weeks, by the end of the month, for sure, I believe. That's going to cover all health conditions.
And we're here in March of 2016, just because you referenced the end of the month.
Yeah, so hopefully end of March 2016, that general registry survey will be launched, and we're going to collect data right away from as many people as we can, and new people will be welcome at any point in time to join it. And, that's going to be a data set that we don't expect to ever have an end to. But periodically, we'll go in and we'll extract the information that we have, and we'll publish what we find.
Yeah. So by maybe late summer, there could be some sort of findings available for us. Is that a fair bet?
I think by the end of summer, we'll be able to go in and we'll be able to look at and try to start linking product type or product selection with health condition.
Right.
I think that's one of the initial questions that I have is, given that people are using cannabis and cannabinoids for so many different reasons and purposes, is there any particular type of product, be it, differentiated by route of administration, whether you're using an edible versus inhaling versus using a gel or cream. Is there any rhyme or reason to how people are using or selecting those types of products across types of health conditions? And then the other major one is to look at whether people are using high THC versus high CBD versus kind of hybrid products, or some combination of products, and whether there's any pattern that emerges that indicates greater benefit for some certain types of health conditions with certain products.
Sure. And with Charlotte Figge, Page's daughter, obviously a partner and part of Realm of Caring, her epilepsy is being treated by high CBD. What can you tell us about what you know or have found in high CBD versus THC applications of cannabis?
So that's not something that I've been able to get involved in yet.
Okay.
So that's something that's a big part of some projects that we have coming up. One of the projects is going to be evaluating exactly that in veterans with PTSD.
Okay.
So we're going to be evaluating cannabis that has been bred to be high in THC, high in CBD, and to have a 1-to-1 ratio of those two substances. To really look to see if that is an important predictor of response to cannabis, again, among veterans with PTSD. It's going to be a big portion of what we look at in terms of initial outcomes with the registries that we're doing with the Realm of Caring. We're working on partnerships with individual companies that are looking to evaluate CBD products for particular and targeted health conditions.
Interesting.
So
okay.
that's going to be an important thing moving forward. And I want to also mention that my interest here goes beyond THC and CBD. I think it's short-sighted that most people focus on just those two compounds,
Okay.
because I think that there's much more to the plant than just those two things that's important to understand. I think not only do we need to look at other minor cannabinoids like CBN, CBG, THCV, and things like that, but we also need to look at non-cannabinoids, terpenes and such. There's clearly, from a pharmacological standpoint, the possibility that the quote unquote entourage effect of cannabis extends far beyond THC and CBD, but there's been very little research on any of those other compounds.
Give us that subject in and of itself has been touched on a number of times throughout the folks that we've spoken to. Give us your sense. I understand that you are just getting to this. Give us your sense, though, of this, what you do know, what you have found, what you're looking to find, as far as the entourage effect, as they say.
Yeah, so I mean, I don't know what the outcome is going to be, and I don't know enough to make any concrete statements about what will or won't happen. But one of the things that I'm very interested in doing is teasing the entourage effect apart in the laboratory.
How so?
And by doing so, what I'm talking about there is basically coming in and administering compounds in isolation in different combinations with each other to look and see how these different chemicals modulate each other.
Right. CBN versus terpenes versus what have you.
You got it. Administer them alone
Yeah.
and in combination with THC, or alone and in combination with CBD, and vice versa, and all. Yeah.
And you mentioned you have lifetimes worth of work in front of you. How do you figure out what to do next? Because as we're talking about it, the stack of papers, I can see them growing on your desk. How do you decide what to tackle next?
Yeah, well, so At the moment, the decisions are made by opportunity. I have hundreds of ideas, and I look for opportunities. And when opportunity strikes, I've been trying to follow that opportunity. And unfortunately, as you mentioned, things are piling up and piling up and piling up because I don't want to lose any opportunities that I'm getting. So I'm having a hard time finding time in my day to get through everything.
Right.
But I think that that's a good thing. And by creating more opportunities, we're going to create more information, and that's going to keep the snowball rolling and piling up. And what I'm hoping is that as we move forward over the next few years, enough opportunities open up that it's not just myself and a handful of other people doing this research. It's an army of people doing this research.
Yeah, there's, speaking of the industry, there's certainly interest and desire is high. The need is explicit. So, I think that everyone is on the same page as far as we've just got to find out, and we've got to give each other the information on how, the plant affects the human.
Absolutely.
Yeah. All right. So we have come to the point where I feel it's a good time to ask you the final three questions. I will tell you what they are, and then I will ask them with one caveat. I want to make sure that you and I talk to each other often. And so I want to make sure that you and I talk to each other at least in 3 months. Does that work for you?
Sure.
All right.
My schedule's open 3 months from now.
All right. I don't mean to put you out, Ryan, but all right, good. So here are the final three questions. What has most surprised you in cannabis? Very much looking forward to that answer. What has most surprised you in life? And then an easy one on the soundtrack of your life, Ryan. What is one song, one track that must be on there? But going to that first question, what has most surprised you in cannabis? Can I ask a guy that's studying the plant that question even?
Oh my goodness. I wish you would have told me that last night so I could really think about it. I think that the biggest surprise for me in terms of a research finding was when I got the blood data from the first edible study, and there was no THC in it. That floored me. And in fact, the first thing I did was I called the lab and said, "You guys screwed this up somehow."
Right. This can't be right.
It couldn't be right.
Right.
But then, after looking into it and thinking about it more, it makes sense. I looked back at the data from dronabinol, and it doesn't come in at high blood levels, and then when you think about the drug THC, it sticks to fat, right? So it's not just floating around in the blood, but that doesn't mean it's not bound to tissue and having an effect. And so I think biggest surprise for me from a research finding standpoint, that was it. The other big surprise for me is that, again, going back to California, we're now 20 years into the legal medical use, and now we've got legal non-medical use of cannabis. Yet there are no widely accepted and adopted standards for the manufacture, production, labeling, quality assurance, safety of the product anywhere.
Yeah.
That is still, I can't believe it.
Yeah.
To be perfectly honest.
And
so
the industry is taking it upon themselves to make sure that there is at least some sort of through line. We just spoke to Juliana Corella again, who manufactures edibles in California, and she said the labs, when we first started bringing our product to them, had no way or understanding of how to test an edible. So they're inventing that process as they go. Certainly.
Yeah, and it's incredibly important, and that's my other biggest surprise. My big surprise is that we still don't have that.
Well,
Okay.
that's,
What was the second
well,
question
I'll get
again?
to it, and I just want to say this is a good. This
Okay.
would be a good point to say thank you for the research that you're doing. You're helping everyone out. The second question was, what has most surprised you in life?
What has most surprised me in life? I guess my biggest surprise in life is that I've gotten to where I am now,
Hmm.
and I feel like it's crazy. I mean, my biggest surprise is that I'm, at Hopkins, a successful researcher with a wife and 3 kids, and a nice house, and life is good. And I gotta every once in a while I have to stop and reality check myself.
All right.
And that's kind of amazing. I would have never, not that I didn't want all of this stuff, but to realize that the path that I've achieved is pretty surprising to me.
Yeah.
I have a job that I love. I can't tell you how many people I talk to that every Monday, oh, I don't want to go to work today. I love going to work.
Right. Right.
I work at night. I work on weekends because it's fascinating and I love what I do.
Well, it's fascinating and it's important and it's needed.
Yeah, yeah. So as long as other people keep thinking that, then I'm in good shape.
Indeed, I have a feeling that you'll be okay. As far as your wife, when did you meet her?
I met her, let's see, back in 1999, right before I went to grad school.
All right. So in Virginia, in
In
Maryland?
Baltimore.
Maryland,
Yeah,
right.
in Maryland.
Yeah.
Yeah.
Okay. Is she from there?
She's from Ocean City,
Okay.
so nearby,
All right.
but she was living in Baltimore at the time.
Fair enough. And she still likes you, which is good, right?
Amazingly enough.
What about the 3 kids? How old are they?
6, 4, and my baby will be a year old next Tuesday.
Okay, so you have utter chaos happening at your house, is basically what it
You
is.
got it. I got chaos everywhere I go.
I guess then it is time for that final question. Some think that this is the easiest question. Some actually find this to be the hardest one. On the soundtrack of your life, what is one song, one track that's got to be on there?
See, I'm on the latter end of that. I could not possibly pick one song that would have to be on the soundtrack of my life, but it would have to be fast. Some old punk rock song that reminded me from growing up and having a good time in Germany with my buddies out there.
See, there you have.
Probably Bad Religion or something like that.
There you have. As far as your punk rock enthusiasm, you have brought more people to the fold as far as you as a person. We now understand it a little bit more, as far as how you approach life, how you approach your science, and where you put things mentally. Punk rock, my friend, is a very specific thing, don't you think?
Absolutely.
What would you say as far as that music? Why is it important to you? Why does it hit you? Why does it touch you?
Oh, it's important to me. I mean, the 2 main things I can think of is, back then the punk rock, attitude and mentality was do it yourself, right?
Yeah.
You don't need anybody's permission to do it. There's no guidelines for it. You don't have to follow rules. I'm not very good at that. So do it yourself and do what you want to do and find the right way to make things happen. That's kind of my mantra.
We love it. Oh my God, this was a great conversation. Ryan, really appreciate your time. Really appreciate your work, and can't wait to talk to you again soon. How about that?
All right, sounds good. Take care.
All right. Dr. Ryan Vandry, very much appreciated talking to him about his research with the plant. Obviously, that's the type of mind that we need to do the work that he's doing. Also, had a good time talking to him about some punk rock. We continued the conversation after we left you. Dr. Ryan Vandry, very much appreciate your time.